Hello everyone, so my name is Nicole Preeter and I'm going to talk about how protein intake correlates with CKD patients who have impaired renal function. So to kind of preface of why I've chosen these two comparisons of the protein and CKD patients. So with our diet history and how modern society is evolving, there's a lot more protein-focused diets that have higher intakes than history has shown, and then lower carb intakes. So the problem with that, though, is how does this trend impact our CKD patients, right? Because there's a very critical amount of protein amongst other macro and micronutrients that these individuals need to focus on. So I wanted to look at how much, what kinds, and how does that kind of run parallel with what's happening in our current society with diets. Probably should get out of the way. So, relevance. CKD is the 9th leading cause of death, and the primary causes of CKD, being hypertension and diabetes, are also on the rise. So as those illnesses increase, we're going to see more chronic diseases like CKD continue to increase with them, unfortunately. So then also, kind of again, how I'm tying these two things together. So the nature of the renal diet, the diet that's prescribed to someone who has CKD, is very restrictive. And it could create any sort of risk for protein malnutrition. So they're living a very restrictive diet, watching how much and the quality of things they're eating, but also then we could in turn not get them enough calories or enough adequate nutrients for their health. So again, very brief overview, functions of the kidneys and the renal system. Very important to remove waste products from our body, activate the form of vitamin D, regulating blood pressure. So healthy kidneys, in the ideal world, someone who doesn't have CKD, they're able to not allow protein to release from the body in urine, proteinuria. I'll refer to that later throughout my presentation. However, damaged kidneys do allow that protein in the form of albumin to leak from our body. And also there is altered metabolic processes that I could really get into, but big picture, it's important to note that urea, uric acid, and ammonia are 3 metabolic byproducts that are unfortunately compromised with someone with CKD. So that ammonia, if that ammonia builds up in the body, because they're not able to either get rid of it through their urine or through dialysis, could cause a lot of problems. Ammonia is very toxic to the body. Short-term effects could cause some delirium, confusion, and long-term effects could cause death, because again, it's very toxic. So again, to reiterate the importance, adequate, not excessive, and not too little amounts of protein are very important to know. However, if we do have higher than recommended protein intake, so someone who maybe does have compromised renal function, and they're choosing to eat maybe something like the ketogenic diet or paleo or Atkins or any of those kind of labeled higher protein diets, they could be at risk for higher intraglomerular pressure, they could be at risk for glomerular hyperfiltration, 2 things that are going to progress and worsen their current disease state. And also this point I'm going to make up next is going to tie into my research of how possibly can low protein diet management kind of save our patients a little bit of money in the short term. Long term, they may have to go on dialysis, but are we able to prolong the initiation of that dialysis with low protein diets? But also adequate protein diets. I'll get into that in a little bit. So again, making sure we're giving them adequate amounts of protein and overall energy, making sure we're giving them the right macro and micronutrients to prevent any protein energy wasting. So it's a really critical and a very finite diet, as we all know, the renal diet. So I just wanted to touch on one macronutrient and kind of how that relates to these people with CKD. So this is a better image that will depict the consequences of choosing a diet that's very rich in protein. So it's going to lead to, again, glomerular hyperfiltration, and then follow the arrow, it's going to cause further damage to the glomerulus, and then it's going to increase the glomerular pressure. It's going to cause more damage, more hyperfiltration, and it's going to keep going on in that vicious cycle. However, A low-protein diet consisting of 0.6 to 0.8 grams per kilogram of protein could have benefits. It could also have risks. The benefits, again, decreasing the glomerular hyperfiltration, decreasing the amount of protein that's excreted in the urine, uremic toxins, oxidative stress, metabolic acidosis, PTH, insulin resistance, blood pressure, and then overall better control of their disease state, hopefully preventing and delaying the initiation of dialysis. However, the risks associated, if we're restricting the amount of protein they're eating now to 0.6 to 0.8, could we also now not be getting them enough calories, right? So an adequate calorie intake, we could possibly cause protein losses, hypercatabolism, inflammation, worsening acidemia, altered glucose homeostasis, and then the big buzzword that I'm going to be hitting on is that protein energy wasting. So just again, not getting them the correct amount of nutrients that they need as it relates to protein. So again, which is worse, our benefits or our risks? We're kind of weighing that question right now. So this is a really handy-dandy chart from my M&T undergrad. It's super basic, but I just wanted to highlight the protein just to show the progression as far as the intake amounts as someone with CKD goes through their disease state. So they're at the impaired renal function. They haven't started any modality of dialysis, whether it's hemodialysis or peritoneal dialysis. So they're at that 0.6 to 1.0. Then they initiate dialysis. Now they're able to eat a little more, 1.2 grams. Peritoneal is also a little more flexible, 1.2 to 1.5. And then transplant, they would have increased needs initially, and then that would taper off after 6 weeks. But I just thought this was a good chart to show from my textbook as far as kind of how they go through that disease state progression and how much protein they're able to eat along with that. So for my research, I'm going to do 1 case study and 2 research studies. And I chose that instead of doing 3 research studies because I think as a very young mind in this field, I'm able to relate well with case studies. We get them thrown at us all the time in this internship and in our undergrad. So it's something I feel that's a little more at my level personally. So I enjoyed putting this case study together and sharing it with you. But then also I'm still going to hit on 2 research articles that's going to kind of discuss what kinds of proteins, how do we know which protein diets to recommend to which patient we have in front of us, and those kind of things. But first I'm going to start with this case study from the Academy. So again, this was a case study that has been formally done and documented upon and discussed and published, and it's on the Academy website if you'd like to further research. However, the case study includes a 22-year-old Hispanic woman who is pregnant and also was diagnosed with stage 5 CKD. So a lot of crazy things happening in her life at a very young age. 14 weeks along, she's on a very regular hemodialysis schedule, and her usual dietary intake revealed cultural preferences of Hispanic foods, coming to about 112% of her recommended energy intake, quite a bit of protein, as you can see, quite a bit of sodium, good amounts of iron, carbonated beverages, not a whole lot of water throughout the day, but she is taking a prenatal vitamin, so that's a good thing. So this is just a chart that was provided by the case study just to show her weights throughout her pregnancy. Helpful to see the interpretation on the right-hand side, just showing that she did have excessive weight gain. In the case study itself, it didn't depict whether that weight was, taken pre-dialysis when she may have had excess fluid on her, post-dialysis where it was a dry weight. However, we can see a consistent trend of excess body weight. So continued assessment, knowing before she was pregnant she did have an overweight BMI, but it wasn't terrible. Her electrolyte and minerals were within normal limits. Her energy recommendations and her protein recommendations were calculated. Very important on this slide to note that her recommendation is 1.2 to 1.5, and although that is quite higher than the 0.6 and the 0.8 that I was alluding to in the previous slide, but this is due to her pregnancy. She's carrying not just herself anymore, she also has a fetus that she's supporting the growth of, so that's why she has increased needs. So, before I go to the next slide, and I give away the diagnosis portion. I want to see if we can use our nutrition or our dietetic minds to think of a possible PES statement for her. Or if we just are shy, maybe just a couple problem statements. But does anyone have any ideas as far as what we might diagnose her with? Yeah.
Increased nutrient needs related to pregnancy and hemodialysis as evidenced by estimated energy needs.
Yeah, that's a really good one. Not personally what they had, but I definitely think that'd be great. Anyone else? No? All right. Well, thank you for participating. So the diagnosis: excessive protein intake related to lack of knowledge regarding nutrition and her CKD diagnosis, and undesirable food choices, as evidenced by proteinuria in her urine, and then also the 1.9 grams per kilogram indication of her protein intake. So to kind of break this down, her proteinuria, like I said, is a laboratory measure that's used to analyze protein losses through urine. Now, for a normal pregnant woman who doesn't have a CKD diagnosis, it would be around 300 milligrams per 24-hour urine collection. However, hers was like triple that, right? So it's the inner dietary recall indicating that she's consuming that 1.9 grams per kilogram. That's already a red flag, but her proteinuria value is also supporting that statement of yes, she's getting too much protein. Second one, undesirable food choices related to eating away from home and a complicated schedule because of hemodialysis sessions, as evidenced by high intake of energy dense and high sodium foods. So that's a more like subjective statement versus like the objective using lab values and her gram per kilogram protein intake. However, both were provided by the Academy. So, and I think both are very fitting for our patient as well as what our participants so kindly contributed. So then our prescription for her, 2,000 calorie a day diet with lesser protein amounts throughout her day, eliminating those high phosphorus foods, as we all know are a part of the renal diet, moderate salt intake, moderate potassium intake, and we're going to try and break up her 3 large meals into 5 smaller portions, and then also ultimately to continue that prenatal vitamin. So discussion, they kind of talked about just the impact of her choices, so what she's doing now and how that's affecting her body, but also her baby's body. Discussing and educating food choices that are very rich in salt and potassium and phosphorus, and then giving her an example of a one-day meal plan and what that might look for her with her renal diet, talking about serving sizes, reading those food labels, of course, so she knows how to calculate protein and she knows how to identify on that label where to find the sodium, potassium, and phosphorus amounts. So following up with her in 2 to 3 weeks, just reevaluating her weights, dietary intake, lab values, and the adherence to the prescription. So then, what happened to Mom? So this is a pretty happy ending, right? So she reduced her intake of sugar-sweetened beverages, high-fat Mexican foods, high sodium, potassium, and phosphorus foods. So that was good. It indicated that she benefited from the education session with her dietitian. Increased her vegetable intake. She was able to spread out her meals into 4 to 5 throughout the day. She was able to maintain that fluid intake, not consuming too much due to her renal impairments. And then overall noting she decreased energy intake, and also very important to note, her proteinuria level indicates that she did consume less because it went from 1,036 down to 640. So that's almost in half. So that was really good education on the dietitian's end, but also good adherence on our patients. So now we're thinking, what happened to baby? So baby was born a little early, which was expected just due to the very complicated state of the mother. And he was born, I don't know if it was actually a boy or girl, so I can't speak to the gender, but it was born early. It had some sepsis, a neuroinfection, just undeveloped lungs because of how early it was born. However, I did read in the end that like the baby did make it out and it was alive and all those good things. Just had some complications at the very beginning part of its life. And then its growth was less and subadequate than other infants, which is expected when it's born this early with kind of a complicated start to its life. So then how does this case study kind of relate to us as dietitians or future dietitians? So renal nutrition is something that I'm really interested in. One of the things I'm very interested in. So it was important for me to read and learn about this case study to kind of take a step back, that it's not just like, you know, you're working with an elderly person at dialysis who is stubborn and doesn't want to eat the right foods. Like it's 22-year-old women my age who are pregnant that you also need to be educated on and have the right tools in front of you and the people around you to truly be able to help them. So the main challenge of this case study that was noted by the panel that put it together was truly just calculating her needs, energy intake, protein, that kind of thing, just because, so she does have that renal impairment with the CKD, but she does have a baby inside of her and she was overweight to begin with. So just trying to weigh all those complicated things to give her a good recommendation was the most challenging concept. And then ultimately, with any research study, there's more research needed to continue our field of work to help people like her. So now getting to the nitty-gritty research portion of it. So we got our case study done, and now we're going to kind of focus on, I wanted to keep my research parallel with what's happening, like I was saying in the beginning, of what's happening with our diet world, as I'd like to call it. So plant proteins are a kind of a buzz, I would say. Just people have their own reasons for why they choose not to eat meat, but how would plant protein intake correlate with the mortality of someone with CKD? So this was a very recent study done in 2016, and it basically looked at almost 15,000 people and who were greater than or equal to 20 years old. And basically, as John has alluded to, the NHANES is a great way to collect dietary and anthropometric information from a large group of people. It's kind of like, I liked what he said, like a mobile home. They go from hospital to hospital or clinic to clinic, and they're able to collect a lot of information all in one place. So they collected the information, like I said, from 15,000, almost 15,000 people to kind of indicate how much protein are they eating, what kinds of proteins are they plant proteins or are they animal-based proteins, and how was that affecting their mortality in CKD. So after the information was collected with their dietary intake, so they were able to collect, like I was saying, it's kind of like the epitome of a dietary intake collection, because it's 24-hour, but it's also food frequency, so you get a true picture of what someone's eating. So with that information that they collected, they kind of separated it. So total protein versus how much of that total protein was plant protein, and then how much of that was animal protein. And with that information, they were able to compare that protein intake with that patient's GFR, which is the glomerular filtration rate, for those of you who don't know. It's the rate at which their kidneys are able to function and process and get things out, basically. So the results. So this is kind of showing like the outline of who we looked at and some brief information. The next slide I'm going to further discuss specifically that plant protein ratio and how that affected everyone's GFRs. But for this slide, some things I wanted to hit on. I thought it was pretty cool and pretty impressive that my bottom point, the plant protein ratio, was as high as it was. It didn't indicate in the study if that was an intentional plant protein intake or if it was just someone happened to be eating some beans in their tacos, or, you know, it didn't show the intention of the plant protein intake, which could raise some more questions. However, it did indicate that between like 33% plus or minus 14% were consuming plant proteins from their total protein intake throughout the day, resulting in 24.6 plus or minus 13.2 grams. Also important to know with this study, there wasn't a whole lot of diversity. There were 10% were African American, and the other major percentage was white, but then there were smaller percentages below 10 that were other ethnicities. But I thought it was pretty cool that it was a very split between men and women. So 48 men, 52 women. So this was a chart I was alluding to earlier. So vertical columns, the Q1, Q2, Q3, and Q4, that is analyzing the plant protein ratio. So less than 22.4% of their protein intake throughout the day was from plants. So plant proteins, just to review, anything that's not from an animal. So legumes, any sort of peanut butter, those kind of things. Q2 shows 22 to 4 to 30, 30.7 to 40.9, and then greater than 40.9. And then truly, you'll see as you work your way down to someone who's incorporating more plant proteins throughout their day, their GFR is increasing, which is positive. A higher GFR is what we want. Someone who isn't diagnosed with any sort of kidney disease has a GFR probably around higher than 60. And then as we get down less than that, we get more into classified end-stage renal disease diagnoses. So what does this mean? So primarily the increased intake from plant protein from gluten decreases our LDL cholesterol, uric acid, and triglycerides, which is beneficial. Also show that increased intake from soy protein decreases our total cholesterol, LDL cholesterol, and triglycerides. However, in the big picture, in the big scheme of things, in our lovely word we like to call moderation, right? Increased intake from plant proteins in junction with some animal proteins ensures more variety of amino acids and a very stable GFR, and also you still have less than normal amounts of LDL cholesterol or triglycerides in comparison to someone who's just solely consuming animal-based proteins. And then very important note number 4, that in our Western diet, more than half of our phosphorus comes from animal protein. So like I was saying earlier, phosphorus is another one of those big components of the renal diet. So we need to make sure that we're tying our pieces together, that protein intake is great and all by itself, but you have to think of other things that are associated with it, like phosphorus. So evaluating the research. Strengths, very recent, had a strict inclusion criteria, very large sample size. I liked the ratio between men and women, so it didn't show any gender bias. And then also very important to note, they use a gold standard for anthropometric collection with that NHANES data. Weaknesses, although it was a very efficient way to collect dietary information, there's never a perfect way to get a true dietary recall. Minimal diversity, as I said, and then since this was a shorter term study, the eGFR was calculated based on a single measurement of serum creatinine. So if we wanted to extrapolate this and measure this on a more long term, there would need to be better ways to analyze that GFR. So the next one. So now we can kind of nod our heads to the fact that plant proteins could be beneficial and would be beneficial for someone who has CKD, right? But now it's like, do we tell everyone to eat soy, right? Or do we need to kind of ask ourselves which low protein diet will work best for which CKD patient, right? Because everyone is individualized. So this study happened over a very long time, 2007 to 2013, and it was accepted 1 year later. So again, it's still pretty recent, within that 5-year mark after the research was accepted. And it looked at 417 stage 4, stage 5, and progressive stage 3 CKD patients in Italy. So it's a research study that was done overseas. And basically, how this happened is the patients were already had a relationship with a nephrologist because they had such an advanced stage. But basically, the research team, doctors, dietitians too were involved in this study, asked kind of these patients, these 417 people, which low protein diet would you like to adhere to as a part of this research study? Which is, I think, pretty interesting. So there was 2 diets to choose from. One was a vegan supplemented diet. The other one was a commercial diet. So then throughout my presentation, if you see the LPD-KA, that's the vegan. If you see the LPD-ACF, that's the commercial-based animal diet. Then there was a control group for comparison. Some of the parameters of this study were 30 to 35 kcals per kilogram each person was able to consume. They had 2 unrestricted meals per week, so they could deviate outside of these, again, to promote moderation and life happens, and It's not realistic to just adhere to something 7 days a week and throughout your whole life. And then also, like I noted, it's very important to note that RDs met with people with complex cases. So like I said, RDs were involved meeting with people who had any sort of myocardial infarction or any food allergy like celiac disease or any sort of complex case like that. There was a dietitian that met with them to make sure that they were able to adhere to their diet. So then this is just a little outline showing the divide between who chose what. So the LPDKA, there was 185 people that chose that. The commercial diet, there was 122, and then there was 110 that had no diet. They were the control group. And then it kind of breaks down any comorbidities that they had, diabetes, any heart disease, those kind of concerns. So the results of this. So it showed that people who chose that vegan supplemented diet were younger, which would kind of make sense. I mean, it's a kind of drastic measure that maybe someone who's older wouldn't be as interested in adhering to. They had less comorbidities and they had more severe kidney disease, which was evidenced by a lower GFR and higher proteinuria levels. It was important to note that vascular nephropathy and diabetes were the leading CKD causes in older patients, while glomerular nephritis was a leading cause of CKD in younger adults. So overall, at the end of this study, it showed that there was great compliance to their protein recommendations. They were recommended 0.6 grams per kilogram, and that was educated, what does that look like by the dietitians for the patients. And on average, it was a 0.6 gram per kilogram at 6 months in both groups.